Next, we are going on to our panel discussion, and it will be focusing on the opportunities and challenges of blockchain in healthcare. And the moderator of the panel is Miss Caroline Maslo. She is a senior medical advisor at Netcare. If we can give her a warm applause.
Thank you, everyone, and good afternoon. I'm very delighted to hold that session. I'm a clinical doctor. I'm mostly working currently in big data, for the hospital group that I'm working with. I'm going to have a short session because two of our speakers couldn't make it now. And in fact, I was on Google and tried to find everything that has been published on blockchain and health recently. In fact, I found that 90% of the publications that I could find were at least 4 years old. So I'm very happy to have that opportunity and to have speakers here to give us some update on what happened, in health and with the blockchain technology. So I start with Gugu Nyathi, who is the founder of the Ribbon Protocol and who is an entrepreneur, but working mostly in public health, knowing that public health is in fact the main health system in most of the world countries, not only Africa, it's all over the world. And it's very important for us to find out how blockchain could support and help with, public health, especially in Africa.
Hi. Okay. Good afternoon, everyone. I'm Gugu. I'm founder of the Ribbon Protocol. The Ribbon Protocol is a blockchain-based health information system that does two things, really. The first is it leverages, blended finance or alternative assets like cryptocurrencies, social impact bonds, development impact bonds to finance public health programs. And this financing would work as loans to governments, and governments would, use that money towards health programs. It could be something like a COVID vaccination program, for example, and governments would pay back with interest. So they'll pay back the nominal amount with about 10 to 20% interest per annum, depending on the demand for that kind of capital. The reason why we started, so the second part, is that it's a health information system. It allows us to incentivize patients, okay? So it's like a reward system. It incentivizes patients as a grant or a soft loan to be able to collect specific health data. So the whole idea with why we created this system was a response from the Department of Health, right, in South Africa. But the same problem is actually evident all over Africa. One of the biggest challenges Africa faces with healthcare is health financing. Every year there is a finance gap. Currently it's sitting at about $70 billion a year. So for the 40 poorest countries in Africa, which are all in sub-Saharan Africa. So that means every year there is a shortfall from governments to be able to finance health, and there's no new money available. The IMF won't give more money. Private investors are not giving more money. So there's always this gap, and it's growing up to about 136 billion by 2030, and that's per annum. So when we had a conversation with the Department of Health in South Africa in 2017, it was about solving this issue. It's a 45-year-old problem. And for 45 years, nobody's been able to solve this. We felt that blockchain and leveraging cryptocurrency and all these alternative tokenized assets could be a way to bring in all these, cryptos to finance healthcare as loans, most likely stable coin loans, but we'll see how the technology behaves when everything goes live. So that's how we believe that going forward, we will finance public health in South Africa. But there is a way that health finance must make it into the system. You can't just throw money in healthcare at a problem. You have to align with certain rules and regulations set by recommended policy from the World Health Organization, the IMF, because a lot of healthcare funding is really tied to other social programs. Because healthcare in itself is not just what happens in the clinic. It's also, what happens in the social environment, in society, where people live and their habits. So that's why we incentivize patients. We incentivize them, adherence to medication, for testing for diseases, for vaccinating, and for, doing all these specific tasks that will help improve their health and be able to improve some type of outcomes or improvement in their health. So that's what we do in a nutshell. And I pass it back to you.
Thank you. I know you're currently running a pilot, you're running a pilot on, supported by, on a public health program supported by blockchain technology. Can you tell us slightly more about this pilot study that you're doing?
Yeah. Okay. So within healthcare, there is a way which you can implement, well, in South Africa for that matter, there's a way in which you can implement these apps or these solutions, because some of them can have some negative unintended consequences. So if you start giving people a lot of incentives, they could go and buy alcohol, they could go and, it could turn out for the negative. So the way to implement solutions according to the Department of Health in the public health sector in South Africa is to first sort of do like a research pilot study. So we've been sort of working around that within a public health clinic, where you go and engage the clinic, engage the community. You identify a principal researcher who will then write a letter to the ethics to get clearance for you to pilot. So deploying a health system is not as simple as just launching another app on Google Play or iStore. There is a process that must go on. There must be clearances, there must be set terms and conditions on what outcomes you are looking to achieve. So we've been working that area. The Department of Health identified clinics in the universities, try and capture information from young people, incentivize young people, because they're already tech savvy. So they identified South African universities, the technical college as the ideal environment. And then we also have some collaboration that we've been working on for a clinic in Soweto as well, where we can implement a similar system in a community of about 40,000 people. Okay, so this system that we're looking at, that we'll be implementing on that front, would really just be the incentivization of patients. So we'll be giving them tokenized incentives, so any cryptocurrencies. So what it means that anybody in crypto that likes to do airdrops could do an airdrop on our platform. So patients can receive that information, that currency, crypto airdrop, and they can do specific activities that generate electronic health data, basically. They could test for diseases, they could respond to some surveys, and provide information that can give better healthcare data insights. So the whole idea is, on one end, we're incentivizing patients to behave in a certain way that will improve their healthcare. But on the other end, you are digitizing the health system, the public health system, because it's still paper-based in South Africa, by the way. A lot of the clinics are still running on a paper base. So there's still a gap to actually digitize the health system and to be able to get, health data insights. So the whole approach is moving towards what they call the national health insurance, where government will pay for healthcare, and for that you will need some type of digital records for all patients to be available on a platform like a blockchain. Yeah. So that's what we're working on at the moment.
So what are the main challenges that you are encountering when trying to run that pilot?
Yeah.
Is it mostly governance, or administration, or rules, or legislation, or the patients themselves?
I think the biggest challenge is really the funding. I think pilots, there's a process, and once you interact with the right people, the principals and researchers, and you have the right relationships with the government, the Department of Health, they're very open to technology, they're very open to solutions. But the challenge is always the financing. A pilot is not like exactly cheap. I think to run a decent pilot for about a year or 2 years can cost you probably about $50,000, and that's money that won't really give you any returns in terms of direct returns, like you make a profit out of it. But the information that you're going to garner, the value of the information, the value of the implementation will be far more in the near future. So when you build for healthcare, you are not going to make, like we see in crypto, a lot of people come into crypto or in blockchain because of, you can make a lot of money in a short space of time. But building for healthcare is like a vocation. It's not different to teaching. It's got to be something that you believe in. You got to believe in people, believe in healthcare, and believe that everybody has a right and deserves a right to affordable or free, equitable access to decent healthcare. So one of the biggest challenges is we have to work with a lot of stakeholders and get money from different avenues to actually run a pilot outside the cost of developing your own solution. But I think the market is changing post-COVID. We've seen more interest since the pandemic of people coming into public health. Prior, I used to have to sell the idea of public health. I used to have to sell blockchain. So there was a lot of barriers in communicating with people, even in government, and explaining to them that blockchain is not such a scary thing. It's not gonna affect patients or users at the end of the day. But nowadays, since the pandemic, public health, everybody knows what public health is. Everybody knows about emerging technologies. So it's really about getting the right people in the right places, because I think there's very little knowledge of what public health in the context of Africa is. When you speak to a lot of even entities that support blockchain, they look at healthcare in the context of private healthcare, like in the US and in Western countries. But in Africa, the majority of the population use public health. So once you get past all these, knowledge barriers, it makes it easier to implement these solutions within the public health system.
So once you have a system that's working, do you think that system could be reproductive to vaccination campaigns, like you were mentioning COVID testing? Do you think that we could use, this kind of platform to launch such programs?
Yeah, definitely. I mean, we saw with the COVID, so the COVID vaccination, for example, the financing for the vaccine finance basically was like a global pilot of a social impact bond, right? Which is, so the Ribbon Protocol enables social impact bonds, enables anyone to create, verified organizations to create social impact bonds. The social impact bond is like what happens with vaccine financing, where private investors or the World Bank put up money, and governments took that money as loans to be able to finance, the buying of vaccines and actually actual delivery of vaccines to populations. But it comes with specific requirements, like a certain number of people had to be vaccinated. So those are called outcomes. So social impact bond financing really is not really a bond in the financial sense, but it's actually like an outcomes-based financing. So it's loans based on a specific goal. So our platform enables that kind of financing, enables us to scale. Part of our platform is a social impact bond marketplace that allows NGOs, that allows governments, that allows health clinics to be able to raise money from crypto holders and from alternative capital, especially social impact capital, to be able to finance health-specific goals. So I think we've also taken some lessons from that. So we've been building alongside policy for a very long time in terms of health policy and social finance and policy. So I think we are currently at the right time in terms of global events and things that have transpired to be able to roll this out to sub-Saharan Africa and start to see improvements in solving this 45-year problem that nobody seems to be really trying to solve. So I hope we are the right people to be able to do that.
Thank you. John Kamara, do you have any experience in public health? I know you're an entrepreneur, and I'm not sure I need to present you the public. You're the chairman of the African Blockchain Center, and I know you're running, Afyarekod. So do you have any insight in how to assist, and or finance or help public health systems with where blockchain technology could really make a big difference.
So the other hat that I wear is I'm the founder for Afyarekod. So Afyarekod is a pure data infrastructure platform for healthcare. And in that data infrastructure platform, the goal is to provide sovereign right of ownership of healthcare data to 500 million people in this continent. And the goal is, by doing that, we're able to reduce the cost of healthcare, and we're also able to increase efficiency, and we're also able to manage the problem of verifiable information in healthcare. So that's kind of the project that we started about 3 years ago. And ultimately, one of the biggest problems that we found across Africa is 75% of population live in rural communities, which means that digitizing healthcare is a very extremely expensive process. And also, which means like over 90%, probably 98% of the people have no idea of their healthcare profile. And the most important data identity for you is not your financial identity, it's actually your health identity. The day you're sick, that's the day you realize that, oh my God, I'd rather be well than have money. And so this is why we kind of decided, okay, what is the first problem? There is no data, and that data is not mobile. But the only way to create mobility in an ecosystem is to use the single node, which is the human being, as the form of mobility instead of trying to create interoperability. So, and to create that mobility, then how do you make sure that that data itself is unique, is transparent, is also verifiable, and has a governance protocol around it? So we started looking at the blockchain technology as a key form of where we're able to first build infrastructure that digitizes healthcare facilities. We have over 100 now since we started in Kenya. But more importantly, as we digitize in those healthcare facilities, how do we layer the blockchain on top of it and actually prove the use case of Web 2 to Web 3? So for the user, they have their health data, but actually they have no idea that it's on the blockchain. It doesn't matter to them. So when somebody else, the insurance provider or anybody else wants to verify that identity, they know that that data, that record is immutable. When the next hospitals, because the mobility then means that the user goes from one hospital to the other, either they carry the data themselves or the data follows them in the network. Again, when the next doctor looks at that data, it's immutable. They can see the layer one data, nobody can change it. Every other forms of data, you can add things to it. You can continue to see the footprint of everybody else. But also what it means as we grow that data infrastructure, which we believe will be the largest data infrastructure in the continent, what that means, if I go from Kenya to South Africa and I go to see a doctor, instantly he can actually verify my health data before he treats me. Before he does anything at all, he has basic level of information, which is verified, that this is true information that came from another doctor in my country of origin, and this is exactly what he was treating me for before he actually started, which means he reduces the time spent, and probably he doesn't kill me or give me medication which happens nonstop. I mean, statistic, 33% of people die consistently because of misdiagnosis, because of the blindsided nature of the movement of data in healthcare. So when you then take that further, you then say, well, on day 2, can I, as John, now use my data through this blockchain ecosystem and monetize it? So I can begin to take packets of data myself and say, okay, today I just want to take my dental data, or the next day I want to take my physiology data, and then monetize it through the network. But I can also track who else is monetizing that data. And also I can decide when I want to burn that data. So literally, you haven't really created any tokens in the economy, but you just use the technology itself. I think, first of all, just to pick on something you said about security, security is an important element, obviously, but I don't think anything is ever completely secure, not even blockchain platforms, because we've also seen blockchain platforms being hacked. But what I think the value of the blockchain where it comes is in audits, especially in healthcare. Because privacy is really the value where consumers are afraid that what if you have my data, what would you do with it? So if I can show you an audit trail that every time I went into your data, this is where my footprint was, and I can't change that footprint. That truly is the one value of that particular blockchain asset in healthcare. It's not security because anybody, a really, really great coder could hack even the best blockchain network. But the audit value, where also for institutions, regulators, where we show them our platform, say, okay, you can IT audit it yourself. You can see every time we make a footprint, this is exact. So even when we try to move the data, this is what has happened. And every time we do that, so we self-govern ourselves. So we develop a self-governance protocol within a consensus network. And everything then means that you can also track the consensus on everything that happens. There is a consent from the other party to say, I concede. But truly the future opportunity where privacy is able to be handled, consumers feel a little safer that, okay, even if you do use my data, somebody will find out. Okay, this can be tracked. It can be visualized. And then on the second part is also information, doctors' networks. So imagine a world where doctors can share information about how they actually did an operation. Where the doctor doesn't have to wait for 10 months to figure it out because another doctor has done it somewhere else. And that information is clear, is stored properly. And this new doctor in a small little rural community can say, oh my God, in this network, this is how one of the doctor did this. This is the type of patient. And it's verifiable information. That is truly where the first power in healthcare comes to place. And the cost of this is extremely expensive. So, using various types, we went through so many different blockchain platforms to decide, okay, well, what would we use on day one? So we use Cardano right now because we like the Haskell language, purely because of the language. The language is extremely interesting in terms of how it verifies information. But we're also thinking to ourselves, we also now have to build our own layer one protocol in healthcare, where we also allow other people in the continent to be able to also build solutions on top of that. And then when you step one step further, I, as a patient, now I have my verified health record everywhere I go from one facility to the other. I have sovereignty of ownership. Now I can begin to transact that health data. The value of clinical trial industry last year was almost $648 billion in terms of value. As a patient, I don't get any of that money. Everybody else gets that money because there's no way that I can track, but they use my health record, my data, my information, and especially in Black communities, in African communities where none of our, genome style data or even different types of health data are used to actually make these new sequence medications that we take because it actually doesn't relate. So I can actually transact that data and say, here is my pharmacy information. Here is my X information. You pay me X amount of money for using it, but you can only use it for X because I know within this network, if it goes past it, I can see that. So I start making money to pay for my insurance using my health data. I start making money to pay for other types of health services, but also the government can also begin to say that now we can start looking at pandemic management and how to actually build single nodes of information using hospitals to now track pandemic, to track outbreak, but to reduce the cost of chronic diseases as well. So really, that is sort of like the future vision of what we're doing since we started 3 years ago to build the layer one infrastructure for health data in the continent, but really based around the sovereignty of ownership. And in that, you have to build so many different infrastructures for so many different pharmacies, to hospitals, to doctors, to labs, insurance providers, because all of this at various layers of health data. If I just to ask people a question today, for you, for example, where do you engage in healthcare for the first time? Your first entry into healthcare, where would it be? If you had a headache, what would you do today? This second, what would you do if you had a headache? You'd buy Panadol. If you had a headache at this minute, what would you do? I said, if you had a headache right now, what would you do? You'd buy Panadol. So that means over 90% of people engage in healthcare via pharmacies in Africa. You don't have a headache now, go call a doctor. It takes you 3 times of actually engaging with a pharmacy before you actually go find a doctor, which means that level of data, information is probably one of the most powerful that happens outside the hospital. Now, securing that data on the blockchain, you start understanding how drugs affect our lives and how those medication affects our treatment in the hospital. So you breach the gap of treatment and healthcare using the single node, which is the patient. 8 billion people, we're all patients. It's just the day your journey starts. And I think that's where the value of blockchain comes in, for that privacy credential that you're able to trust the custodian that, yes, my data is, private to me.
I think the privacy is something very important, the privacy of the data. We still see many patients that won't go to be treated for tuberculosis or TB or HIV because they are afraid about the lack of privacy of the data. For a very long time, until almost now, even if you're hospitalized in a hospital and so on, if you happen to have TB or HIV, it won't be even noted, in your report, in case, the report, could be seen or read by someone else. And of course, that impacts on your health, because it's very important for the healthcare workers to know that you have this disease. So I think that the privacy point is a very important one, especially in Africa.
No, it's the most critical part of, patient-centered healthcare. Is my data private to me? In current Web 2 healthcare ecosystem, in hospitals, when you go to a hospital, at the pharmacy, at the reception can see all your health data. They can see what's wrong with you. Well, she has no right to see that information. And then whatever, but nobody knows that she sent that information because there's no real trail. And even if there's a trail, she can change the trail because she can access it. Whereas the blockchain makes it impossible, and you can create multiple permission protocols. Then at the same time, consent, especially in this world of GDPR, or HIPAA compliance or GDPR, where you're then saying, well, did you consent for me to use that data? The blockchain also allows me to create verifiable consent, which means if somebody comes to sue me later on and say, well, no, I didn't, look at it here. You actually consented. Every time something happens in the consensus network, it's actually stored and it can't be changed. So it's immutable. So you also know. So for us, really looking at, how do you demystify, blockchain technology in healthcare, we focus on patient data, privacy, and the mobility of that data to then create a sovereignty where, as you say in Kenya, the Mamaboga who lives in the rural community can have some basic access to her health record on her USSD form, so that when she goes to the doctor the next time, she says, hey, I was suffering from malaria, these are the medications they gave me, and this is what you should look at before you start treating me.
Thank you. So if we look at how the medical field evolved in the last 20 years, 20, 30 years, you look now, medical aids are, in fact, in medical aids, you find more actuaries than doctors to manage, your conditions and to decide if you're allowed to have this or this surgery or not. Most of the things, except complex cases, will be managed by algorithms and AI, to decide if you're entitled to have this medication or not. If you look at hospital groups, it's now mostly an IT business with few doctors that are helping here and there, but you need one doctor and you would need 20, 30 IT guys when you're building an electronic patient record for one doctor, I'm talking about management implementing the system. At the end, on the ground, you still have doctor, nurses. But in fact, all this industry has kind of involved in the place where the technology is now the one which is managing everything. And doctors, you have few doctors here and there that try to adapt and still, manage some individual cases when they can. So what will prevent us to start using blockchain technology, is it mostly regulations, or what's really blocking here? Where can we start, to do something or to change something? What would be the starting point?
I think opinion, again, is not, it's not anybody, it's not fact. It's just my personal opinion. I think the way we convey the technology to the people who make decisions, they don't understand it. we talk too much about technology, but we don't actually focus on the problem they have, the value of the problem that they have. I mean, I can talk to you about protocols from day one, from here all the way to next year. I can talk to you about models and theories, but when I go to see the Minister of Health, he has no interest in any of those things. He just wants to know, how is population healthcare affected and what is security? Now, if I send my CTO to that meeting or some really super, he's just lost him. And he would never believe. And the only thing he'll say is, this is cryptocurrency, I'm not interested. So really, we do language is a very important part of how you actually connect. Then the second part is, you also do need to understand that the people in these positions also have their own agendas. Okay, and a lot of the time we go to them with our agenda. This is my agenda. You should do this. But he doesn't care, because he also has other things that he has to worry about. So you do need to find a point, where is his agenda, and how does the agenda that I'm bringing support or help him on day one? And once I'm able to figure that out, and I'm able to bring that to him without necessarily telling him anything about its great, awesome forms of technology. And I'll give you a very good example. So we work with the nuns, the mission hospitals a lot in East Africa. And the mission hospitals are over 14,000 hospitals in Africa. They see almost 348 million patients every year. This is the largest network of clinics you will ever find. Not even governments. They're like a government to themselves, powered by the Catholic Church. And the amount of money in there. So, but these nuns were like sisters, and they are, bless their soul, they're amazing. When you go to talk to them about technology and you say blockchain, all they've ever heard is cryptocurrency, ever. And all they ever read is this, the negative or positive thing. So when I talk to Sister Regina and I say, look, what is your biggest problem? She said, is the data safe and is it private? Yes, this is how I'm going to make the data private, because I am implementing a simple solution. Every time I go into the platform, every time I do anything, I can't change that information. So if the regulator comes to audit my platform, they will see that. And also your patients can request information from me about the audit. And she says, oh, okay, that's good. I like that. Have I mentioned blockchain? No, I'm not going there with this coat of grades that, oh my God, blockchain. But I'm at the back end, I'm going to implement the blockchain technology. Then I tell her about verifiable, I tell her, and also that once this happens, every time somebody goes, they will consent before anything happens. She said, I like that. And every time they go, they can take that data and somebody else can verify it. Throughout the whole conversation, I have not mentioned blockchain, tokenization, none of those things. But Sister Regina and her clinic is on the blockchain, and they're in a rural community, and they have no idea about it.
So everything is about education. Okay, education, and maybe because many people confuse blockchain with the cryptocurrencies and everything which is linked to cryptocurrencies. So yeah, I think it's mostly about education.
It's just understanding who you're speaking to. In these places, we can talk about it because we understand, but there's certain understanding the audience that you're going after. Once you understand the audience, where their level of education, knowledge is at, and also their thought process, and the identity of how they think about situation, because there's already a paint of blockchain and crypto all tied together. It's very hard to. So understanding that audience and saying, okay, with this audience, this is how I will approach the conversation. I will still achieve the same thing, but I don't need to, paste blockchain on her. It doesn't make any sense for her. When I go to the regulator, but when I go to a government who's interested in blockchain because they feel there's value there, then I talk blockchain.
But to be honest, I didn't ask the IT guys in my hospital which technology or basic technology they were using to build the databases on the warehouse. So it's also, we just trust them. And so maybe that's also a way, just another technology.
It's just another form of technology that is extremely valuable to the continent, and especially for healthcare is immensely valuable. But even at the same time, how many times have we put healthcare regulators in a room like here and actually trained them through a process? None. The regulators in cities, in local governments, in counties who handle collect data, how many times have we brought them in a room and trained them and gave them some capacity? How do we assume they should just know? it's a lot of assumptions that we keep making all the time.
Gugu, do you have that experience with regulators and,
I think the one thing that we learned early on, we used to screen blockchain, but it was, people were scared of blockchain back in 2017, 2018, until we really started to look into the IT policy, like for South Africa and other countries. And they've actually got a 20-year-old policy on open source technology, right? Blockchain, a lot of blockchain is open source, So we started talking more around open source, because what governments want to find out is that if you're building in healthcare, or you're building for government or public services, they want to know that your technology is open, you're building an open platform, because they have to align with those policies. So there are state information and technology agency policies that enable or allow for open source technologies to be implemented in governments, right? So you will see in South Africa, there's the healthcare, there's stuff like home care, there's GEMBI, they produce a lot of the public health technologies all over Africa, and a lot of it is open source technology. Okay, so what governments really want, like interoperability of technologies, and the open standard and the open sourcing of it makes it easier. So they don't want to pay for IP. They don't want to buy your solutions. They rather use it and pay premium usage. So we stopped talking blockchain and started saying, look, it's an open platform and they need open doors. And we stopped talking about cryptocurrency and said digital assets as an alternative financing and it open doors. And now we're speaking their language. We're talking about blended finance. There's a policy within World Health Organization, USA, PEPFAR, and all those guys for using blended finance to finance, public healthcare. So that's the language we're speaking. We're saying, look, we're bringing alternative digital asset, and we'll provide the liquidity to finance or to give government loans for healthcare. And that opens doors because it's their language, they're listening to it. So we've changed how we speak. We're not marketing blockchain. When we speak to the blockchain guys and we want them to bring their airdrops, we'll say, yeah, bring your airdrops to your platform. But when we speak to government, we'll say, look, we've got behavioral incentives for your patients. So you see, it's the same thing, just, different languages for different audiences, like John said. So those are the lessons. We need to change how we talk so we can open more doors.
Thank you. So I think we're going to stop. So to just summarize, I hope you all saw that there were many opportunities in healthcare, even if we didn't even touch half of them. I'm talking about medication, safety, and so on. There are still some challenges, but the most important thing is that everything is moving on. And I think it's going to be more and more, easy, to people are going still to get much more familiar with these, these terms and this terminology. And thank you to the speakers.
Thank you.